welcome again to the Surgical Clinics podcast. Surgical Clinics is a bi-monthly publication consisting of review articles devoted to a central topic important to general surgeons. Surgical Clinics has published for over 100 years, and the series and the podcast can be found at www.surgical.theclinics.com. I'm John Vassallo, the managing editor of the series here at Elsevier, and for our 10th podcast, we'll focus on the December 2023 issue on emergency general surgery. While trainees are increasingly pursuing specialized fellowships, it still remains important for general surgeons in the community to be able to identify, diagnose, temporize, and treat general surgical emergencies. Here to discuss 4 articles from the issue will be our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editors of the Emergency General Surgery issue, Drs. Viren Punja and Paul Schnartz, both in the Department of Surgery at Creighton University School of Medicine in Omaha, Nebraska. Welcome to all 3 of you, and over to you, Dr. Martin.
Thanks, John, as always, and welcome, PJ and Viren. It's a pleasure to have you here and at least spend some time with you virtually this morning. As you know, we've tackled a very broad topic in this issue, and emergency general surgery could really cover just about anything one wanted to. And we have, as per our usual format, we picked out 4 articles that we think at least get the readers and the listeners off to a start on how this issue will help them understand what they need to do. We've got, as I mentioned, 4 articles to pick from, and we're going to start off with one on basically resuscitation in the emergent general surgery patient. PJ, I'd like to start with you. This article written by our friends Brett Weibel and Andrew Kamian, who did a fantastic job and bit off an enormous amount of work to cover this. But I think I would like to, for openers, get your thoughts on sort of how we approach resuscitation in the emergency general surgery patient a bit different than we do in, say, regular trauma patients or other patients who are getting ready for the OR. But we'll sort of start focusing off with optimization and what that means. But why don't you give us your general thoughts about how, we'll call it EGS for the sake of time, how EGS patients differ in their needs for initial resuscitation?
Well, thanks, Ron. That's appreciate that question. I think that speaking for my co-editor, I think that was our whole purpose in this edition of Clinics was, general surgery emergencies are different than trauma in a lot of ways. They have some similarities, but, different than trauma, I think the frequency in which an emergency general surgery needs to be performed, and we really don't have a standard approach like ATLS. And so I think, when evaluating the emergency general surgery patient who's in extremis, I think certain aspects are similar to trauma. For example, a very rapid history of allergies, medications, past histories, the events is good. But I think it differs in that, number one, you have to identify the need for surgery, not just, what are the organ systems injured. I think the second is, while you're figuring out what is going on, you also have to simultaneously resuscitate them. And I think in some ways, emergency general surgery really focuses in 2 big areas, and Brett Weibel has brought this out in the article, and so has Andrew, in that typically in emergency general surgery, it's bleeding or sepsis, and the approach to bleeding is pretty similar to the trauma approach, where you're focusing really on restoration of perfusion, not normalizing hemodynamics. And you may not be able to actually get the patient fully resuscitated before you go, because really the treatment is going to be stopping the bleeding. In emergency general surgery, where you never see this in trauma, is the septic patient from perforated viscus, necrotizing infection. And they're really the tenets of the surviving sepsis guidelines of, volume expansion, blood pressure control, early antibiotics, and source control, I think are the hallmarks. And I think you have a better chance in the septic patient of optimizing them for a safe induction into anesthesia quicker or more effectively than you can maybe with the bleeding complication. So I think that's where they differ a little bit.
I'm with you on that. I mean, let's unpack. There's a lot in there, but let's unpack a little bit of it. I mean, you and I have been doing this together and apart for a long time. But one, we're always forced with a truncated timeline.
Yeah.
And that probably is the common element that runs through all this. But as you say, if we parse this out from the trauma group and the emergency general surgery group, whatever that holds in that bag, one of the big differences is most of the trauma population, their organs were working okay right up until the incident.
Yeah.
And in this other group, as you say, depending upon whether it's hemorrhage or sepsis or both, but odds are other organs were starting to underperform, misperform, or just plain fail prior to their connection with the healthcare system. So to me, that's like one of the big differences is you're already an emergency general surgery patient, for the most part, you're already behind the power curve by the time they know they're sick.
Yeah. No, and I agree. I think that I learned this maybe from you, maybe from someone else, is everybody looks good until you put Betadine on them. And I think that's really true, as you say. I mean, very few people come to general surgery emergencies with no other comorbidities. And later in this edition, Greg Schaefer, and I think we'll probably maybe talk about this later, talks about palliative surgery. And, I think I think one of the very first branch points is should you continue the resuscitation? We can talk about that more when we talk about palliation, but I think that's really different branch point. I think, and then how do you optimize each of the organ systems? The cardiovascular system, just as an example, is I think really challenging to optimize because we have older patients now. They're on medications which disrupt, their normal physiologic response. And so the idea of just, giving them a few liters of fluid, maybe a little bit of blood, and getting into the OR isn't quite as easy. And so I think, optimizing their perfusion with measures, if you want to look at like a lactate or some other dynamic measures, such as echocardiogram or passive leg raise, might be better over, your more static measures in a healthier population.
Yeah, and I think that one of the themes of this morning's discussion is going to be understanding when you're playing chess and understanding when you're playing checkers or marbles or whatever non-chess analogy you like. But, I mean, if we look at the commonalities of underperfusion, possibly shock, possibly dysregulation, then, as you say, we boil it down, at least in the EGS group, into the hemorrhagic folks and the septic folks.
Yeah.
And the responses have to be different. And I think one of the things we want to emphasize to the readers and to anybody who does this is you have to know when the operation is part of your resuscitation and when it isn't.
Yeah, that's a good point. That's a great point. I think the other area where it differs a little bit is, in a trauma save resuscitation or with bleeding, very rarely do you use, any vasoactive medications. Where in the emergency general surgery population, you will use them, in sepsis, but you also may use them in optimizing, the cardiovascular performance in somebody who's, got cardiovascular disease. And so I think that I think our whole focus when we approached this was for the practicing general surgeon. Where are they similar and where are they different? The end is that did a great job as we were going through this, finding people who were not acute care surgeons to to talk about the emergencies and how to do that. And so I think that that's, not only in this chapter, but, throughout the, for the readers, throughout the this edition, that has been sort of our focus is the non-trauma approach to each of the organ systems. And I think, at least in my reading of it, of course, I'm biased. I think we were able to attain that goal through the effort of the other authors.
I mean, I agree with you both, especially about just the emotional surgery, the patient to not confuse resuscitation with a way to delay source control. It's okay to do that initial resuscitation, but you don't want to waste too much time doing that because you're going to get behind the eight ball, and it's not ideal to not take them to the operating room in a timely fashion. And sometimes I think there's that tendency to wait on it longer than you should, and there's not a lot of, older folks, and a lot of times the EGS population, they don't have the reserve to tolerate that delay.
Yeah, one of the things I learned from Ron as an intern, so you may not know, I was an intern under Ron when he was a chief. And besides being the surgical voice of reason, the other thing I learned was, the safest place sometimes to resuscitate a patient is in the operating room. And it doesn't necessarily mean you even have to be performing the surgery. I mean, just being in a monitored environment where you can act quickly. I think maybe the best option in some of these cases, and something that we shouldn't forget.
Yeah, there are very few facilities that have better resuscitating capability outside of the OR than inside of the OR.
Yeah,
I'm not aware of any, unless you have no OR personnel at all for some reason. But one last thought on this before we move along, because as I said, there's a lot of commonalities, but I'd say the biggest change in the last decade or two, in my opinion, that drives this is the change in our use of anticoagulants writ large. And in this group, it doesn't matter what you're doing. Doesn't matter if it's for bleeding, for sepsis, for scheduled procedures, you name it. One has to be versed in what are the implications of the modern DOACs, NOACs. So what are your thoughts on that?
I think it has become a complete hot mess. It has become very, very difficult. And I think one of the tables, and I'm just trying to find it here, table 1 in Weibel's paper, I think, talks about the, different agents that are used and how to reverse them. And I think that, there's not an easy thing. It's not like in the old days where it was, somebody's on Coumadin, you give them fresh frozen plasma, maybe some vitamin K. Now we have different factors. I would recommend to folks, and I'm an old guy who writes with fountain pens, so I would cut out that table or put it on your phone so that you have it immediately available to you. I think Brett did a really good service to all of us by putting that table together.
He did. Now, if only the hospital pharmacy stocked everything.
That's right.
It'd be even more useful, because that stuff is like beaucoup expensive, and a lot of places you just can't get it in a timely fashion.
Yeah, no, I mean, here in Nebraska, we're sort of a unique state in that where Creighton sits, is a pretty urban area, but you get rural and even frontier. Yeah, a lot of those places do not have these available to them. And unfortunately, you may have the brain and the skills to operate on some of these emergencies, but I think just resource limitations wise, the better course of valor may be to move them so you can, optimize them as best you can. That's not a failing if you don't have the resources. It's just wisdom and maturity.
No, agreed. And I think we're going to get into that a little more, a couple articles down the road with Viren. But I'd like to shift gears and chat with Viren a little bit on colonic emergencies. And that can be described in any number of ways. But this is from our colleagues Pantel and Reddy, and they did a fantastic job with it. Some of what's in their article, I mean, it is expansive, and I encourage anybody who's interested to read through it. We have another issue coming right up that's just on colon surgery and IBD and so forth. So we may truncate some bits out of there in deference to what we know we're going to be doing down the line. But so, Viren, I mean, in this, I mean, to the way everybody has their acronyms, the one I used to use to teach people was HOPE, like the tribal name, for hemorrhage, obstruction, perforation, and incapability to medical care. I've heard people use IHOP and other acronyms, but the chapter sort of focuses predominantly on hemorrhage, obstruction, and perforation. So when you look at that and you compare it to your other standard colonic procedures, give us your 30,000 foot view of how you feel those differ and where we start to separate our thinking on those.
I mean, this chapter's done a really good job of, going over different colonic emergencies. I think it focuses on 4 things: malignancy, diverticulitis, inflammatory bowel disease, and functional emergencies. Like you said, IBD will be covered in the colorectal piece. I think that's not what I want to focus on here. But as far as malignancy, it's usually 3 things that you're operating on or going to need to operate on in that emergent setting. It's if someone's obstructed, if they're perforated, or if they're bleeding. So regardless of whether it's obstruction, perforation, or hemorrhage, it just comes down to hemodynamic stability and what how stable or unstable someone is. If they're unstable and they're about to perforate or have perforated, they're going to get some resuscitation and go to the operating room, and there's going to be things like antibiotics, sepsis guidelines, all of that en route to the OR and in the OR as well.
So of the things we were talking about, hemorrhage, obstruction, and perforation, let's carve out perforation first. Maybe, I don't know if it's necessarily the easiest, but it seems to be intellectually the most straightforward. You got a hole, you have an abscess, you got free air, you got your work cut out for.
Yeah, from a perforation standpoint, you think, especially if it's a malignant perforation, you're looking at an obstruction, and it's either at the site of the tumor or it's proximal to that because there's been backup. And usually what you'd want to do is resect that area off the tumor, if with following oncological principles, vascular ligation, that sort of thing. But you also want to get the hole. And you either, depending on the stability of the patient, in most instances, you're going to do a Hartmann and bring out an end colostomy. If it's more proximal that the perforation has happened, you might have to do a more extensive resection, beyond the limits of what you would need in a malignant scenario, and have to do something like a total abdominal colectomy with an ileostomy. So those are kind of like the options you're left with in a perforation situation. You're generally not going to try and put these people together, and even if you do, you would divert them with a loop ileostomy because you don't want to subject them to the possible complications of an anastomotic leak, and that might delay further sort of adjuvant therapy down the road that they'll need to get as soon as possible. So, ideally you want to do the safest thing in that scenario, not, you can deal with the reversal down the road, I think.
So, I think for perforations, if you can control the aberrant exit from the GI tract, then you can decide. There's a whole litany of literature on who do you put back together, who don't. If you put them back together, do you divert them proximally? Do you not? How much do you take out? How much do you leave behind? There's many, many right answers to that question that are situationally dependent. But I think in the hemorrhage group, sort of the adage is, with upper GI hemorrhage, you're curious, is it arterial versus venous? With lower GI hemorrhage, you're curious, is it right versus left, or you can't tell? So I still think that there's a role for that, although interventional radiology has upped the game a little bit in terms of very specific embolic procedures.
Absolutely. So hemorrhage in the setting of a tumor, I think just having IR around has changed the game tremendously, because that buys you some time. If you're able to kind of localize where the bleeding is, embolize it, you can still do your staging and then do an oncologic resection. And that gives you some time, I think. Whereas to go into that blind, not knowing where the bleeding is from, that's a slightly different scenario.
And as you say, I think the other part, particularly with malignancies or potential malignancies, the unstaged patient presents you with a series of challenges that you really have to ask yourself, how many bridges do I have to burn today versus trying to get myself a definitive plan I can execute a little more elegantly or efficiently. But obstruction to me is always the one that creates the most issues for the most people, especially those who never worked in the open era, because there's a lot of options for relieving obstruction that a lot of people who are practicing today have never done. And there are some that have come along. So at least to my thinking, the big issues are we have stents, so unobstruct people without making any incisions in them. We have diversions, which have come in different varieties. And then we've got resections. So, what's your strategy as to how, so you have an obstructed patient, you don't know why, you just know they got a large bowel obstruction. How do you approach that?
I mean, you got to figure out, first of all, either by endoscopy or some sort of fluoroscopic exam, where this large bowel obstruction is. Once you figure that out, I think it depends again based on, on the stability of the patient. In a stable patient, especially for left-sided colon cancers, I think stents have provided a great option, not just as palliation, but as a bridge to therapy down the road to have a resection. But of course, you have to be mindful of how long the stent is going to stay in place while you kind of get your ducks in a row. So at 6 days is when the stent complications seem to exponentially increase because of regrowth of the tumor, migration of the stent, erosion of the stent, all these sorts of things. So you just have to be mindful of that. There was a thought that anything that you can reach through an extended right colectomy, you shouldn't use stents in those scenarios, but those indications for stents have now extended even further down into the right colon. So you can use it on a short-term basis. And then as far as resection, we talked about a curative resection with either anastomosis and proximal diversion versus just a resection with an end colostomy. And then there are rare instances where if you feel if it's a locally very invasive tumor, or you're not going to be able, or the patient is too unstable, then even now things like a loop colostomy is a reasonable option, or just some sort of just a loop diversion to kind of get them out of trouble and maybe put some drains in through IR and stabilize the situation before you go sort of tackle the mass, or figure out a plan to maybe do some neoadjuvant and then treat them.
Yeah, I think the one situation that I have found most of my junior partners to be unfamiliar with, because they're not old like me and they didn't train before laparoscopes, but it's the person who's got the T3, T4 rectosigmoid obstruction, probably cancer growing into the sidewall, and the competent ileocecal valve with a threatened colon. And those are the people that side decompressive colonic procedures, Turnbulls, et cetera. Those are the people that are made for it. And almost nobody's ever seen one. Because every time I don't do them often. I've probably done, 4 or 5 in the past decade. But at the time for each one of them, it was the only thing to get you out of Dodge. And you do that, you can then decompress them, take the heat off the big picture, and then go back and evaluate them. And on every single one of these people that we did a Turnbull on, we found a synchronous lesion on further evaluation, which has got to be a statistical anomaly because they're not supposed to be 100%. But I think but just understanding that the goal when these people come in with this is to relieve the obstruction. That's the emergent piece of it. The tumor, you're going to want to deal with that because it presented off hands, but it's to do that. And I think, to me, that way of thinking is a little bit the same way of thinking about diverticulitis, which is the other thing I want to spend a couple minutes on, is that regular diverticulitis, you got a million options to deal with, the uncomplicated version. But for the complicated versions, and we'll forget the fistulae for the moment because they're not really emergent, we've got the obstructions, the perforations, and the strictures. I'm not aware of people being super keen on putting stents in diverticular strictures. I mean, has that been your experience as well, or?
Yeah, they don't even want to scope those patients. So no one really wants to put a stent in an inflamed colon. So I think that's fraught with complications. So really, we don't use it in that setting. But complicated diverticulitis, like you said, that's where I think there's been a paradigm shift in how we like treat it. Meaning, there's more and more tendency to try and treat these non-operatively and try and get them out of Dodge as best you can. Wait for the inflammation to come down and then do a resection wherein you can do a restorative resection and have bowel continuity restored and not really give them an ostomy. We know that from the existing literature that a lot of people that end up getting ostomies, they don't get reversed very often. The morbidity associated with the reversal is much higher. And sometimes it's just better to be able to put them back in. Even if you did a loop ileostomy, the morbidity from taking down a loop ileostomy is much less than taking down a colostomy. So that's kind of where this has all gone. And I think, even societies of colorectal surgery, whether even in HINKI 3, HINKI 4s, there's a push to try and ride these people out if you can, and then bring them back and, put them back together when you do the resection. Whereas if you subject them to an operation at the outset, you kind of you oftentimes don't have an option but to give them an ostomy.
No, I think you're right. And I think that's where it becomes imperative to not just think about the operation you're doing now, but think about the last operation you're going to do. And I'm with you. If I can get somebody into a position where the last operation I'm doing is reversing a loop ileostomy, I am much happier than if it's something else.
On the same note, sort of like, when you're trying to treat them non-operatively, I think part of it also is motivated by the fact that you might be able to do the second. When you do operate on them, you might be able to do it laparoscopically, and you may not have to go open. So that, that's another reason to try and write it out, because, depending on how long you wait, you might be able to get it done lap.
Yeah, that's one where a lot of people, including my partners, feel that way. I'm less concerned about open versus laparoscopic. We've been following, before the laparoscopes came around, and I realize it's like saying before the dinosaurs left the earth, but there was a huge move to small incision operations. And, we found that even when we do like a volvulus the other day, big cecal volvulus through a small midline incision of about 3 centimeters, and the patient went home the next day. One of the things we learned from doing laparoscopic procedures was that we were holding on to people for open procedures too long. But still, to me, whatever you need to do to get it done safely is all that matters. I do find a lot of people walking away from a good opportunity because they want to save it till they can use a laparoscope or a robot. And I understand that. And sometimes that's good, but sometimes maybe not so much. But the important thing, I think, is to get yourself to a position where the next procedure is as low morbidity as you can make it, by whatever means. But I agree. If you're going to start taking out big chunks of colon, I'd rather use a laparoscope. But if I'm going to be going after something focal, there are ways to put your incisions in places that don't mess you up too bad. Yeah. But this kind of moves us into the next part of the logic of that, which is damage control. And there's an article in the edition here from Carlos Fernandez that basically talks about damage control operations. And I think that we need to look at damage control operations and contrast those with damage control resuscitations.
I think this chapter kind of talks about 3 or 4 things. One is damage control resuscitation. The other is damage control surgery. And as part of primary fascial closure, it also talks about other modalities like direct peritoneal resuscitation. So that, a lot of what we know comes from the trauma literature, and at some point, damage control surgery began to be used in trauma, and there were demonstrated benefits. But I think at some point, things kind of swung too far, and there was an overuse even in trauma of damage control surgery, leading to a lot of people being left open for too long, kind of not ending up with big ventral hernias, and other complications like your intra-atmospheric fistulae. So it's not without complication. And I think there's a realization now that there is a place for it, but I think the patients have to be sort of chosen well, and you got to use it appropriately. Part of that is also damage control resuscitation. I think they're all sort of part of the same thing, meaning a lot of damage control surgery in the trauma setting is because of excessive hemorrhage. A lot of the hemorrhage has to do with coagulopathy, metabolic exhaustion, loss of factors, acidosis, lethal triad, that sort of thing. And if you can minimize all of that and make the resuscitation appropriate, wherein with our better understanding of coagulopathy and having TEGs and this sort of thing, we're able to correct a lot of these things. So the resuscitation is a lot more targeted. And I think that kind of decreases the number of people that need damage control surgery itself, because you don't have as many people bleeding as much. And you're able to get them closed quicker because they've been stabilized within that 24 to 48 hour period, after which primary fascial closure becomes increasingly more difficult. So I think that's how those two are interconnected. And so we're trying to find out in the EGS population, how, are there certain things that kind of tell us that these sorts of patients are better suited for damage control surgery. So whether that's in the EGS population, again, you're looking at either hemorrhage or sepsis. And in both of them, there are specific sort of variables that have been looked at, like your pH or systolic blood pressure, what your INR is, how much blood you've received throughout, and so on, or lactate and sepsis. And those patients tend to be the ones that are probably going to benefit from it, because even though there are similarities in the demographics between both your trauma patients and EGS patients, there are some differences. There's more like elderly females, there's more people with a high Charleston morbidity index, and so on. So there are differences, and you got to pick the patients out appropriately, I think, for them to actually benefit from damage control surgery. And how long you leave them open is key. There's a lot of variability in how long people are left open in the US versus Asia. For instance, here the median is 4 days. In Asia, it's about 7 days. So the ICU length of stay also expectedly is higher. So you really want to keep the number of days of leaving them open as little as possible. And then coming to direct peritoneal resuscitation as a part of primary fascial closure, it essentially has to do with instilling the peritoneal cavity with some sort of hypertonic saline. And it works much like a dialysate, where the solute concentration in the fluid is high, so it draws fluid out of the bowel wall and kind of decreases some of the bowel edema and sort of decreases your chance. So yeah, just talking about direct peritoneal resuscitation and how that sort of helps maybe close the fascia sooner. But the studies have also shown that there are some more complications associated with direct peritoneal resuscitation. But it is an option, and I think it's something to consider. And as far as primary fascial closure, there's different ways that have been described. But essentially now we look at some sort of abdominal vac system with fascial tension, whether that's with suture or mesh, that helps kind of not lose domain, so to speak, and helps you get the fascia closed. And usually when you want to do that at about 48 hours, that first take back, I think, is important. Not waste time to the first take back. Try and take them quickly, and then instead of having what you call scheduled retake backs, do on-demand retake backs, wherein if there's something changes, then you take them, and if not, you just plan to close them as soon as you can.
No, I agree with that when the situation permits. And one of the questions that comes up is, what options do we have in environments that are more austere, less resource rich? And I think that in some ways, on the fringe of this discussion is the concept of second look operations. And I think a lot of times second look operations in the modern era of imaging are underutilized. Particularly if you're in an austere environment, and PJ and I spent some time in various mountainous and desert lands with nothing but a tent and a stethoscope. But my second looks and takebacks are frequently within 12 hours, because that's what you got, and you just working your way. Now, we're not in the mass casualty format here, but I agree with you. I think these long takebacks are what people get into trouble. They just start swelling every place. And I think a lot of the take back philosophy just evolved over, I'm going to put them on the schedule somewhere or whatever. This is my OR day. And I understand those pressures, but to me, it's like, especially the kind of work I do, every day is my OR day and every night is my OR day. So if I'm working, I'm working. That's just the way it is. And I'm not saying that's right or wrong, but it allows you a lot of latitude to just do what you want. And for a lot of patients that they're cold, coagulopathic, acidemic, what have you, it usually doesn't take me more than 6 hours, 10 hours to impact that meaningfully so that I can go back and take a look at things before they've gained another 20 kilograms of crystalloid or whatever we're resuscitating them with. So I think one thing is go back, or like voting in Chicago, go early and often. It's probably the way to go when you're getting out of the OR because your patient's not optimized to continue operating. Take care of that as quickly as is humanly possible, and then get back to it. Don't sit on one's laurels. But I think the temporary bowel closures, assessing perfusion. I mean, certainly we have other tools now to assess perfusion that we didn't used to have, ICG, et cetera. Better in some environments than others, obviously. But I think the idea of, get to the bottom of, take out the life-threatening problem now. And if that means bringing up a stoma to do it and coming back at a later day to hook things back up, or in places where you don't have stents, doing some quick, easy decompression procedure, those are the things. Because I think, as PJ mentioned earlier in our discussion, you have to look at what resources are available to you at your place. And at Creighton, you guys have the full gamut. When I was in the bigger hospitals I worked at, we had pretty much everything we wanted all the time. But I worked in smaller facilities where you're kind of it, and you got to make do with what you've got. And I think the one thing you always have is you've got a little bit of time to stop doing what you're doing and come back to it. So to your point, getting people closed, or at least as long as you're not dealing with, obviously abdominal compartment syndromes kind of define the opposite of what you can't work around. But short of that, you can kind of get people back somewhere where you like. And hypertonic saline is a good choice, using temporary, synthetic material to minimize, splaying of the field. Those are the things I think you have to work with. And maybe to PJ's point a little earlier, if you get to the point where you've got this done and you don't have the capacity or the wherewithal, or you're just exhausted, you're an N of one and you got nothing left, or you're taking care of the 5 other people that came in sick, then getting that patient transferred to a place that does have the resources might be the right next move. And in the Army, we did that all the time. We operated on somebody in a forward station. We didn't hold on to them for a week or two. We moved them on. That's how the system was built.
Yeah, and I think this is where, like, the ACS, EGS sort of format we have, where we have a bunch of surgeons, is useful because, even if you're post-call and you just resuscitate a patient for 12 hours, that take back can be done by the next person. And, each time, as long as people are thinking to close the patient and avoiding just sort of meaningless washouts, wherein, like, all the correctables have been corrected, I think you should be trying to close. And you have to go in with that mindset.
I think you're right. I think the other advantage to working in places with a lot of personnel, and the thing I strongly advocate for everybody, is surrender your ego, call in one of your partners who isn't exhausted, or call in somebody from a different specialty and say, take a look at this with me now, make sure I'm not missing anything. Can you see a reason not to close? Can you see a better way to close? Because sometimes you've been into it, you've been trying to keep this patient alive for half a day, and your brain's not always perfect. You get locked into your way of thinking. Not you personally, obviously, but one does. I do. But calling in a fresh set of eyes sometimes is just the best thing you can do. Or even calling up somebody if you're alone, who's far away. My phone rings at all hours of the day and night with text pictures from Dallas about some patient with some pancreatic problem, and happy to take the call. Surprised people still remember to call me sometimes. But that's one of those things we need to do. I think, given the time, we're probably going to round out the last chapter here that we're going to discuss for the morning, PJ, which honestly is really an extension to all this. Where the chapter's one on palliative emergency general surgery, So, PJ, I'm going to lead you in with a very lopsided question, but start talking. I mean, my old boss used to tell me you can't palliate an asymptomatic patient, which I believe to
Right.
be axiomatic. So we're always talking about if we're going to do palliative something, we're trying to make somebody's symptoms go away. They got to at least be sick from it. So the question's going to be, in 4 words or less, what's the difference between futility and utility? No, you take as many words as you want.
Well, so I'm going to push back a little bit on the symptom thing a little bit first, if that's okay. And I love you like a brother, but I do think that palliation doesn't have to be you're in the middle of a crisis. And, there may be a time where you can foresee, for example, that someone's going to become obstructed or somebody's going to, biliary obstruction, and that you're not going to, they don't have symptoms yet, but you're going to prevent them from developing. So I might take a different view on that.
Well, just in the spirit of back and forth, I would say that in that group, they don't fall into the emergency general surgery category.
True. So I would agree with that. All right. So, I think that we go through training and practice, looking at, surgical benefit versus risk. And I think when you get into the palliative arena, it's a complete mind shift. And that, the benefit here is, I think it's very, very difficult. I think it's difficult for 3 reasons. One is, we spend a lot of our training and a lot of our practice pulling people, out of really bad situations. And palliation is not I think, a normal surgical response. I think our response is to do as much as we can. I think we're wired that way. And, to steal your term from a moment ago, you have to surrender your ego. And it's about what's going to be most beneficial for the patient, most comfortable for the patient, and shifting to that as opposed to there's many things we can do. There's only certain things we should do. And so I think when you're in the palliative arena, it really comes down to, what is going to make this patient have a good quality of life over what is the, big operation that you can perform. And I think you have to, it requires, I think, all of us to step back a little bit from our mindset of, we can tackle, anything. I mean, we can remove, metastasis out of the liver or sarcoma, metastasis out of the lung. And whereas in some of these settings, it's really about, what's going to be long-term beneficial. And similar to our talk on resuscitation, all of these patients typically, or many of them, have a chronic condition. And now they have rapidly decompensated. And really, I think the role of palliation is almost talked about too late. And that should be something early on with, what if, you do an operation on somebody, say, for an obstructing colon cancer, and you get them out of that mess. What's going to happen in the future? Maybe that's the time we should start talking about it earlier.
I want to expand out what I'm hearing your definition to be, because I think I like it. But I mean, basically, if we take the Schnartz version of my original comment, we're not interested in just palliating existing symptoms, but palliating predictable symptoms and problems as well. And if we broaden that out a little bit, we're intervening with the intent of eliminating a symptom, a problem, or some other mal outcome without necessarily eliminating the underlying disease. Say, for lack of a better term, curative intent. Now, if we think about that writ large, we really just described vascular surgery for the most part. I mean, it's, focal operations done usually on a systemic disease. Now, certainly I don't want to offend our vascular friends. We love them, but there's emboli and there's direct injury and there's things where you're putting things back to right. But for the atherosclerotic crowd, we're really trying to maintain perfusion and head off something bad happening. There are analogs, as you discussed, pending obstruction, and other things that will go wrong. But I think, to me, everything we do is palliative to some degree. We all know where it ends up, and it's not pleasant to think about all the time, but, that no one gets out of here alive. And so our operative goals are supposed to be to give people the best course through life that they can get and influence the minimum amount of harm upon them to achieve those goals. So I guess the thing is, in the article, there's a fair talk about risk assessment, which, so give me your view on that, because I think that's hard sometimes to sort through.
So I may have an atypical view of the risk assessment calculators, and there are several different ways to do it. What I have found in my experience, and maybe I'm just jaded, but that they're almost used after the fact to say, like at morbidity conference, like, look, we had this complication, and the risk calculator said this would happen 97% of the time or so, and so I think that to be effective, they have to be used really in the preoperative setting. And maybe that happens to a greater or lesser degree, but I think it's hard for people to put, for patients to understand what some of these calculations mean. So if figure 1 in their paper, for example, gives an example of, death occurring in 82%. And for some people, they would say, wow, that's pretty high. But other people might say, that means I got a greater than 15% chance of dying. And I'm willing to take that. And so I think that it has to be, they're useful for discussion, but I think in the end, it comes down to your relationship with the patients and sort of taking them through what the immediate complications may be, but also what the, what the next steps are. I view these sort of discussions sort of like playing pool. It's not about the shot, it's about the leave, and it's about what you can do next and what's going to be needed. And, so I think some of these things like readmission, return to the OR, sepsis, some of the other outcomes aren't as helpful, I think, in discussions as like discharge to a nursing home, which I think really carries more and more weight. So I think there are some good calculations that are out there. I think frailty is probably, to me at least, the most useful. But in the emergency setting, the die's already been cast. You're stuck with the situation you have, and I think it comes down really to the discussion. And having these tools to aid in your discussion is going to lead you to where you want to go, rather than the patients aren't ready, I think, or the families aren't ready to just get hit with a bunch of numbers.
No, I think it has to be put in context, and I agree with you. It's, an 80% chance of not surviving an operation is terrible if you've got a 80% chance of survival by not operating, but it's great if you've got a 0% chance of survival without operating. So, I mean, you do have to compare it to the alternative. It's never, and I agree with you. There's a lot of things that are brought up after the fact in M&M to justify the decision making that didn't have to do with decision making. It wasn't my fault because the number said, "Oh, this always bad happens" or something. And that depends on who's moderating M&M, whether somebody should get away with that or not.
But I also think it depends a little bit on where you are. And so I think if you are the private practice, smaller group, rural setting, You may not decide to undertake, some really horrible situation. That might be completely reasonable. I do think there are times at bigger academic centers where if the patients, we're not violating any patient's desires, to try the heroic thing, because I think that helps advance science and advance our care. And so I think it depends a little bit on your setting, and it depends mostly on relationship with the family and the patient. And I think that's very challenging in the emergency setting, because most of these patients with chronic medical diseases have been cared for by an internist or a primary care provider. And then all of a sudden there's something happens, and, you have to immediately establish rapport in an emotionally charged way under a time constraint. And so I think that's where I think getting some additional help is useful. A second opinion or a palliative care colleague or even someone from another discipline to step in and provide sort of support to the family, but also provide some emotional support to the surgeon out there making a tough decision.
Yeah, and I think, to your earlier point, it's not about our goals, it's about the patient's goals. And maybe the patient and their family, depending on the dynamic, but it's still, it's shared decision-making with a common understanding. And what we as surgeons strive to be is good at explaining complicated things to people in short periods of time. We hope that we're good at that. But I think, and the other thing, I think it's fair to tell people that we might go and try something and we may find out when we get there it can't be done. And if it can't be done, then it can't be done, and you've removed diagnostic and therapeutic insecurity, and you now know what you're up against. And I think, at least in my experience, and I know you and I have done this together in the past, that helps a lot of families to know that they weren't leaving something on the table. And if you make it a point not to harm somebody badly and to make sure that whatever you do, you control the symptoms of as best you can, I think that's helped out a number of people. Certainly not everybody, but a lot of people feel better knowing that they gave it their best shot, or they.
Well, and I think too, there's a place when you're in the operating room, if you get to a branch point where you're like, I can't, this isn't going to work. We had hoped it was going to work. It's not going to work. We may have to fall into some of those damage control strategies that we talked about before. But I think there's a role really for stepping out of the operating room and talking with the family and saying, okay, hey, this is where we're at. What do you want to do? Obviously better with the patient and try to outline it, but you can never foresee what you're going to find inside. So I think that ability to step out is useful.
But this is where, in the preoperative discussion, the person with the wider range, the best understanding of the widest range of possibilities you're going to find, is better suited to have that discussion with the family up front. And I think where people paint themselves into a corner is they don't have that broader discussion. Now, of course, you can broaden it out to the point where you're reading the entire textbook or something. But the people who are like, oh, there's this one thing and this is what we're going to do. And now it's not at all what they found, isn't at all what they told the family, and now they don't know what to do. So not so much laying crepe, but making sure that people are aware of the range of possibilities. And with modern imaging and everything else, I don't get as blindsided as we used to.
Well, and I think one of the things is it's a real art in communicating with the family. And I think using imaging and showing what we see is good. In cardiac arrests, now this is going to be completely bizarre maybe to everybody except for me. Yeah, but in cardiac arrest, and I've done this in trauma, bringing the family in during the resuscitation so they can be there, I think gives some closure. And it's got to be done carefully. I've often wondered in circumstances where you look in there and you say, wow, this is just not fixable. Is there a role for putting the, family in a bunny suit and mask and just bringing them and saying, hey, this is what we're seeing and this is why we're making the decision. I've always wondered if that would give them closure. I mean, we do bring patients in for, donation after, before cardiac death, the situations. I've always wondered if that would, if it certainly is out of the box thinking, but, I always worry about when you're performing these palliative things, we do this all the time, and it's not a sentinel event in our life, but it is a sentinel event in the life of the family. And so I do think we have to think about how the family walks away from this experience thinking everything that could be done was done, and I've got closure. And I think that's an important part that, again, we don't talk about on the boards. We don't talk about at M&M, but I think just as physicians, it's an important thing.
No, as I say, the most important thing about patient care is taking care of the patient, and that means taking care of them and their family. And at the end of the day, it's a very human thing. And you're right, we don't quantify that, but hopefully, outside of the academic rigid structure, hopefully we teach that. Hopefully we teach that by example. Be a person first. There's the usual detachments you need to make good surgical decisions, but just the last bit in this chapter, I mean, sort of thinking about it in terms of, there's a lot of focused operative problem solving, which I think is one of the general tenets, really, of anything, but of palliative surgery. And then some of the more generalized things, I know they were sort of looking at tracheostomy, feeding tubes, et cetera. There was one interesting statistic I can't just let slide. And then talking about survival after these, one had a median survival of 0, which there are no such things as medians of 0. That statistically doesn't exist. I don't know how that got past us, but if it's something has a median survival of 0, nobody survived across the board. It's not a statistic that matters anymore. That's called a clean kill. We probably shouldn't advocate for that, but I'm sure it's a matter of just how it was looked at. But any sort of last thoughts?
I guess my last thought is the same as my first thought when dealing with palliation, and that is you have to surrender your ego. And there's many things you can do, right? You can do many heroic things, and we're trained to do that. But the shifting of the mindset as to what I can do and what is right to do, I think is really hard for people. And I think I know it's hard for me personally. Like you had talked about, our deployments and stuff where how to do stuff you just can't. And that takes a lot of maturity. And so I hope that our younger readers can learn from some of this. These are challenging decisions. They're not, because other clinics, as are based on, melanomas and, what cool things we can do with these advanced, terrible problems. And this is one where you have a terrible problem and you may have to go back to just some basic, doctoring. Well, thanks, guys. This has been a lot of fun.
PJ and Viren, thank you again for spending your time with us this morning, especially since it's a little earlier in your time zone than John's and mine's today. But really appreciate all the work you guys have done, all the work your collaborators have done on the issue. I really cannot recommend highly enough to our readers to read the entire issue. This is at the core and the soul of what general surgeons do under tough circumstances. And even if you're in one of the subdisciplines, subspecialties, this is all stuff you need to know. We all overlap our problems with other people. So thank you again. Fantastic issue, fantastic discussion. We really appreciate your time.
Thanks, Ron, for having us.
Thank you, Dr. Martin. Thanks, everyone.
Thank you for joining us for the Surgical Clinics podcast devoted to emergency general surgery. The 4 articles discussed, as well as 10 others, are in the December 2023 issue, Volume 103, Number 6. The series is available for individual print or online subscriptions. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter at Surgical Clinics, and you can find our podcast on most major audio streaming platforms. Visit theclinics.com for more details. Thanks for listening.